So I am Yvonka Hall. I run the Northeast Ohio Black Health Coalition, and actually one of my operations director is here. So Saronica is here, and she is our operations director. And we have been doing this work I've been doing this work for about 25 years. So my mom was murdered in front of myself and my younger brothers, and I promised myself that I would use my life to help change the lives of other people. And so that actually led to creating these cutting edge programs to address the issues in the community. And so one of the things that we talk about, and that I've been talking about for some 25 years, is cultural competency. And why is it important to our community? And why is it important for engagement in the community? So I am a board member with MACC. I've been with MACC for, I want to say 4 years. But before that, I had did some programs with them when former Senator Charlita Tavares was heading MACC. So the Multi-Ethnic Advocates for Cultural Competency is a statewide organization that is committed to transforming systems through the implementation and the sustainment of concepts related to cultural competence. We are a clearinghouse for training, resources, research, best practices, and collaboration. And we define cultural competence as a continual learning process that builds knowledge, awareness, skills, and capacity to identify, understand, and respect the unique beliefs, values, customs, languages, abilities, and traditions of all Ohioans in order to develop policies to promote effective programs and services. And so it's a key word in there that says continuous learning process. So I think a lot of people think I took a cultural competency class, I'm good, and I don't have to learn anymore. But cultural competences are a continual learning process because things change, people change, communities change. And so we do this whole continuation of reinventing how we look at the people that we're seeking to serve. Our vision is for diverse populations to achieve equitable outcomes. The mission, bless you, to implement cultural competence concepts and tools into policies and programs across systems. And that's important, and that's a little harder because to try to get systems to actually understand that they're having some issues is one of the things that keeps us going. And so what we do is we provide these cultural competence trainings, cultural needs assessments. We do a statewide conference and regional lectures. We have a resource library. We do interfaith outreach, cultural audits, and we do technical assistance. Understanding our key terms. So what is cultural competence? So cultural competence is a continual learning process that builds, and we talked about that, and promote effective programs and services. So one of the things with the Northeast Ohio Black Health Coalition, when I'm talking about defining cultural competencies, is we're talking about promoting effective programs and services. So cultural competency really doesn't talk a lot about people, but cultural proficiency does. And so in my work, I talk about being culturally proficient, because cultural proficiency is understanding how people work. So cultural competency, we're talking about systems, how our programs working, are they working to do the things that they need to do? Cultural proficiency is understanding how people work, what's going on with the people that we're seeking to serve. And we call it cultural awareness. Being cognizant, observant, and conscious of similarities and differences among and between cultural groups. Having a firm grasp of what culture is and what it is not. Having insight into intercultural variations. Understanding how people acquire their cultures and culture's important role to personal identifiers. Life ways, mental and physical health for individuals and communities, and being conscious of one's own culturally shaped values, beliefs, perceptions, and biases. Observing one's reactions to people whose culture is different from our own, and reflecting upon these responses. How are we responding to other people who are different than we are? Seeking and participating in meaningful interactions with people of differing cultures and backgrounds. So last November, I was in Ghana for 3 weeks. And totally different culture than me. So, people think all black is black and all black ain't black, So even though my DNA says that I'm 99.99, I'm like about 94% African. It was like, I'm African American. I'm like truly, like the cultural identifiers and things that are going on in their culture were like oblivious to me. Like the things they eat, like there are certain things that culturally, like that my family that I realized came from the motherland, that I'm like, yeah, my grandmother liked her food real hot. Like, her food is so spicy that it's like, grandma. But then I remember her mother eating sausage and things when I was young, and her stuff was always so hot. And it was so hot that she had to like eat something to cool it off as she ate the hot stuff. So when I went there, I'm thinking, oh, I'll just order rice, because I already have like these funny eating habits here in the States. So I'm like, okay, so I'll order the jollof of rice. So the first jollof came, and it was like hotter than hot. And then they gave me an extra cup of hot, like, hey, this is some extra stuff to put on there. And I'm like, oh, okay, I'm good. And so I think I ate like Townhouse crackers and peanut butter that I brought from America, like for 3 weeks. And the people that were with me kept saying, yeah, we never see you eating. And I'm like, yeah, because I got a whole stash of Townhouse crackers and peanut butter in the room. And so, and what is culture? Culture often is unconscious, is a characteristic, the knowledge of groups of people defined by a multitude of elements, which include but are not limited to dress, religion, spirituality, rituals. You know, what do people do that are different than other folks? Food. You know, talk about that food thing. Celebrations. How do we celebrate stuff? How do we celebrate weddings? How do we celebrate? What do we do when we go to funerals? Like, one of the things I found out when I went to Africa is that I had like all these little black cute dresses that I wanted to wear. And they were like, yeah, black means you're going to a funeral. And I'm like, oh man, I can't wear my dresses. So red and black were funeral colors. And so they were like, yeah, we would suggest you don't wear those, because people will be walking up to you the whole time saying, are you okay? Are you okay? Thinking that you're in grief. And I'm like, okay, yeah, those will be staying right here. Rites of passage. You know, what do we look at in our communities around rites of passages? Whether we have rites of passages programs in the African American community, or Jewish celebrations for young people, or even Hispanic celebrations for young people. The values, family roles. You know, what roles do family play? You know, are all things that are related to culture. Social economic status is a thing that's important. Look, me and these nails in this thing. Public or social behaviors. You know, what do we look as norm? And what's the new normal? Language. You know, like we had this whole thing around Black English, you know, or Ebonics, or, you know, how young people speak to each other, the things they talk about. And then Snoop made his own language, and it was like, oh. Decision-making processes. Who makes the decisions in the house? For some houses, it's the man. For some other houses, it's the woman. You know, for some cultures, it's group thing. Like the group, they sit down as a group and talk about, like, these are decisions that we're going to make. Sexuality, a big one. Health habits. And, you know, one of the things about health habits, particularly since we're talking about chronic illness, is, you know, when you're going to the doctor, for women who are of different religions and ethnicities, when they're going to the doctor, having a man to see a woman is not good. And so understanding that in that culture, that is not something that we want to do. And I remember that when I worked at the hospital, there was a young man who was Latino who came into the clinic to be seen. And when he came in to be seen, he was having a mental health issue. And they insisted on throwing him in a room with a female. And he wasn't having it. Like, he was in there. And so here they bring me, the person who speaks no Spanish. Go in and find out what's wrong with him. Okay. And I went in and I determined that he had a family history, and that his mom, and he called it nervous issues, and that he felt better about talking to men. And so let's go find a male doctor who can speak Spanish. And I went and found one and got him in with him, and he was fine. And it was all because it took the time, because, you know, they weren't taking the time. They were just like, this man is going crazy. Go get Yvonka. And I'm like, okay, well, I do STDs and HIV. So how did I get pulled into this? Disability status and others. So we may have other things that we look at when we're talking about characteristics and knowledge of groups of people, and what actually defines the elements which are included that are the basis of culture. Race versus ethnicity. Race is often referred to as a biological category based on genetic traits like skin color. So this comes from Health and Human Services in 2001. But there are no reliable means of identifying race through biological criteria. It is instead a social construct to describe people with shared physical characteristics. And you know that because when you go to the hospital, I know that I haven't had anybody ask me if I'm black yet. But I look at my medical record and it says I'm black. So somewhere along the way, somebody made a conscious decision that this is who she is and we're going to put it right here. Categories identify. Am I right? Has anybody ever asked you what your race is? No, because there are black people who look like white people. You know that, right? And so when you go to the doctor and they're looking at things for you and they just automatically assume you're white. And then all of a sudden you have these illnesses that are like non-traditionally white. And they're like, yeah, I don't know why you got that. And it's like, yeah, because I ain't white. You know what I'm saying? So categories identify, because I have an aunt who's, categories identified by the U.S. government include African and Black American, Asian Americans, including Native Hawaiians and other Pacific Islanders, Hispanic Latino, Native Americans, white Americans, 2 or more races, like how do you want to identify? And so those things are important because we're going off of what people are identifying. But a lot of times what happens is when we're in systems identify for us. So we need to make sure that we're telling them who we are so that we can get the services that we need. Ethnicity. It implies a certain sense of belonging. It is generally based on shared beliefs, values, beliefs, and origins rather than shared physical characteristics. The category identified by the U.S. government, Hispanic Latino, racial categories contain non-Hispanic or Latino and Hispanic or Latino Americans. And then we talk about explicit or implicit biases, that all people hold levels of bias. So we do know that everybody has something that they're biased about, right? It is important to note that bias can be detected by others as it may manifest in physical responses, your body language, your tone of voice, your eye contact to members of a particular group. So understand that all people hold their own biases. We have people who don't like skinny people. We have people who don't like fat people. We have people who, like, oh, your hair is dark. I don't like it. Or is that your real hair? I get this whole thing where people think my hair is fake. And then all of a sudden, I'm like, why is your hand in my head? Been at church one day, like, about to lose the Holy Ghost up there. Like, did you just walk out of your seat and touch my hair? Explicit bias refers to the attitudes and beliefs we have about a person or group on a conscious level. Much of the time, these biases and their expression arise as a direct result of a perceived threat. Like we see a young person we don't feel comfortable with, and then automatically we shift our pose either to the left or to the right, or if they're getting on the elevator with us, we like holding on to our purse a little tighter, or holding on to our phone a little heavier, or I'll call somebody that we wasn't trying to call, just so we can say we're on the phone with somebody, because if something happens, I want you to know that I was on the elevator on the 3rd floor and people got on and they look suspicious. And the person's like, yeah, what you doing? Yeah, I'm on the elevator. Okay, well, call me when you get off the elevator. No, just stay on here with me, until I get off. Implicit bias occurs when someone consciously rejects stereotypes and supports anti-discrimination efforts, but also holds negative associations unconsciously. So you're not even thinking about it. This is like, it's just there. So why does cultural competence matter? Which is the most important reason I'm here. It's changing demographics. So communities across Ohio will steadily become less and less homogeneous, and it must therefore identify strategies that ensure inclusion of diverse populations. But what I do want to go back to is the bias part. So in Columbus, probably about 5 or 6 years ago, like they have a large Somalian population in Columbus, Ohio. And so they had a clinic day for that community. And so somebody decided to do a fire drill. Well, to do a earthquake drill, some type of drill, right? So they ended up taking them down into the basement. And so in those old buildings, like in the old building that used to be the Heart Association, we had everything off in these cages, right? So we had these cages, like as soon as you walked in the basement, all you saw was the cages. That's where we like stored all of our stuff. So you see where I'm going. So they started walking them down into the basement and they saw the cages and people just started passing out on the steps. They started screaming and the people who just totally just clueless, I don't know what's wrong with folks. Okay, do you not understand what you just did? Like you just caused all kinds of emotional trauma to people who were already traumatized. And now they're here and they're thinking, okay, what's going to happen with me that happened there? It's not going to happen here. And now you walk them downstairs and say, okay, well, get into the cage. Right? Most bizarre. And just for the staff, for their response, like, I don't know what's going on with these people. Like, what's going on with you? And that's why it's important for us to understand the cultural competency isn't learning about cultural competency isn't just one-time hit. That is something that you keep on developing because things will arise that make you, okay, look, I have to really work on this. So Ohio foreign-born populations were 13.1% in 2014, according to the Census Bureau. So 20.9% of families speak a language other than English at home. More than half the nation's children will be from minority groups by 2020. So that's right now. And the United States is projected to become a majority minority nation in 2045. And that's important because you have to be able to understand the people that you're seeking to serve, regardless of whether they are foreign-born populations or even populations that are here. And just like I said before, all black ain't the same black. All white ain't the same white. People who are living in different communities, who are living with different social economic statuses, have different responses to different things. And so that's important for us to understand. So this is the National Geographic prediction of the average Americans in 2050. You see that? And so you see like all of these different shades and hues and a little scary. So, but just look, at the, when we're talking about predicting, like this is what people look like. I remember seeing a commercial like this when I was young. That had like people changing. It might have been a Michael Jackson video. Was it a Michael Jackson video? When the people started changing in the video? Yeah. Was it black or white? Was it black or white? Where people all of a sudden started changing and morphing over to, yeah. So he was a man ahead of his time. And so the lack of cultural competencies equal to health disparities. And that's one of the things that you see when we're talking about lupus. Health disparities is a particular type of health difference closely linked to social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on race and ethnicity, religion, social economic status, gender, age, mental health, cognitive, sensory, or physical disabilities, sexual or gender orientation, geographical location, or other characteristics historically tied to discrimination or exclusion. So the source came from Health and Human Services in 2011. So when we talk about lupus, we talk about disparities in lupus, and I'm sure you've been hearing this all morning. So women develop lupus at much more often than men. 9 out of 10 people with lupus are women. Lupus is 3 times more common in African American women than in Caucasian women. As many as 1 in 250 African American women will develop lupus. Lupus is more common, occurs at a younger age, and is more severe in African Americans. And it is not known why lupus is more common in African Americans. And so this is the source. It's the Lupus Foundation is the source. So coming from a family who, I had an aunt who had lupus, and for a long time, when we were younger, we could not figure out what was wrong with her. Like, she would go to the doctor, and, you know, it's like, okay, well, what did the doctor say is wrong? She was having problems with her breathing. And they said, well, you don't have asthma. Like, we can't figure out why you're still having this problem. And then she started having some other issues. And it took them years. Literally, I want to say it took about 25 years before she finally went to a specialist. And the specialist said, you had lupus. Like, she had all the symptoms. Like, I remember, you know, when I was growing up, I remember seeing her cheeks and looking at her cheeks and going, okay, why do your cheeks look like that? Like, why do you have these spots on your face? And she just kept saying, you know, why does she have this butterfly? And she said, you know, I've had it as long as I remember. But when I go to the doctor, they tell me I'm fine. There's nothing wrong with me. They can't quite figure out what's wrong. And so my aunt passed away with heart complications probably about five years ago. But her dad was born in 1870. And she had complained about what was going on for a long time. And so when I talked to my grandmother, who was 89, she said, yeah, I think that my grandfather had lupus. And, you know, which is rare for men, but men have lupus. And she said, I think that he had lupus because I remember him having some of the same issues that my aunt had. And so, you know, just thinking about, you know, what happens with people. And I remember one of my girlfriends had it. And so when we would go to places that were really, really hot or really, really cold, she would have like these brain meltdowns. She couldn't remember stuff. You know, we couldn't have the room too cold. We couldn't have it too hot. And so it was like this constant, like, trying to make sure that she was okay. Like, are you going to be okay? Because we would do these travels. Like, we go to Florida. It's hot. You know, it's like, well, she can't go out during the daytime because it's too hot. And then she moved to Vegas. And I'm like, you moved to Vegas, like the hottest spot? And she said, you know, we can't go out in the daytime in Vegas because it's too hot. And I'm like, why would you move to Vegas? And she said, well, because of the air quality. You know, so the other thing is that it was hot, but the air quality was a lot better. And I'm like, wow. And so just thinking of how people move because of that, because of the things that are going on with them. And then when I was in Africa, the air quality there was totally different than here. Like, I could breathe. I felt good. I could, like, leap. I could run. Yeah. I thought all of those things. I really thought I could do all those things too. But I was there for respite because I'm not feeling well. And so facilitating culturally informed interactions. You know, how do we facilitate these culturally informed interactions with other folks who are different from who we are? And so we have to understand that cultural competence and cultural proficiency and cultural awareness, it starts with you. It starts with you and how you perceive other people, how your interactions with other people, what you're willing, how much are you willing to come out of your comfort zone when you're interacting with people who are different from you? What does cultural competence look like? Frame issues and provide explanations in cultural competent ways. So understanding who you're talking about, understanding the community and whether you're framing issues and talking with them about it, talking with them about how it impacts African Americans or whatever group you're speaking to. Understanding the complexity of the issues based on a cultural context, historical racism, powerless, etc. Being respectful of culturally specific meanings of touch, hugging, shaking hands. You know, everybody don't want to be touched. Everybody don't want to shake hands. And, you know, with Corona, you know, people like, yeah, you can stay all the way over there. And then adjusting your communication styles to the client's culture. Like being able, like, if it's backing off or being a little closer to be able to talk to people, you know, understanding culturally, how do they communicate? You know, like some body languages or hand signals. For other folks, they trying to do karate on me? What's going on here? You know, but other folks talk with their hands. You know, I'm one of them. You know, I talk with my hands. And then interpreting the client's emotional expressions, considering considering their cultural backgrounds. So looking at them and seeing, can you see that it may be some other things they may not be getting it, even though they're nodding and they're actually doing and you like, yeah, you understand what I'm talking about. And they're like, and they like, yeah, when I get out of here, I don't know what she was saying. Being willing to explain and adapt your role and practices is needed. So being able to have that adaptability, with folks who are talking with you and are presenting with you, and understanding the historical context, because I think a lot of times one of the things that happens, particularly with the African American community, we get a whole bunch of people that tell us to forget stuff. Yeah, forget about slavery. So when we talk about the Middle Passage up until the Civil Rights Movement, that actually represents 87% of the African American experience here in America. 87%. So since the Civil Rights Movement, it's only 13%. So when you tell people like, oh, you need to get over that, you tell them to get over 87% of what they know. That ain't happening. So when we say, oh, get over it, and people are going, did they just say get over it? Whole different conversation. Like, oh, well, we're not even going to talk about racism today. And the person is sitting there like, what? Well, how can you not? And endorsing a collaborative approach to planning treatment, like talking to the person, like how are you going to talk to them about food? That's a whole big thing culturally, particularly when, different kind of foods and different kind of medicines, kind of different kind of interactions and things. And so you're talking to somebody who's used to eating something. Like, we eat this all the time. You're like, yeah, you can't have that no more. And they're like, what? Oh, I'm not hearing anything. She says, as soon as I leave out of here, I'm getting the very thing that she just said that I cannot have. And so obtain and integrate culturally relevant information and themes. That means being able to do some research on who you're working with and understanding, what's going on in that culture. Select culturally appropriate screening and assessment tools where necessary. So making sure that whatever your screening tool is that you're doing as an intake, that is not biased. That is, a screening tool that's actually being able to get to the root of the problem without the person feeling like they're being violated. And then saying, okay, I'm never going back. And we know people like that, where they've gone to appointments and they're like, yep, I ain't going back there no more. And determine readiness and motivation for behavior change if necessary. And you may be talking to someone who's not really ready for behavioral change. And you're saying, hey, I need you to do this. And they're like, not feeling you. I'm good. And, how are you going to get them around to who you are? And that takes time. So working with clients and building trust takes time. It may be more than a one appointment, drop in and you're out. It may be, hey, dropping by for lunch. I remember I had a patient who was chronically ill who just would not come in for her appointments. So they sent me to her house. Like, I'm telling you, I did HIV, STDs, and I wasn't supposed to be at this woman's house. But they said, hey, will you go and see how she's doing? And so I went to her house and I knocked on the door and she came to the door because she was the only person, like I was the only person she talked to when she would come to the clinic. They're like, she only talks to you. But everybody else, she cusses out like every doctor in the facility. So I went to her house, I knocked on her door, she opened the door, and she said, what you want? And I said, I'm here because you didn't come in for your appointment, and, I just want to see what's wrong. How can I get you to come in? Do you need a ride? Do I need to give you bus tickets? And she said, you gonna say it from the other side of the door? And I'm thinking, oh, do that mean come in? Oh, okay. Like, you just stood there. So I went in. So I'm standing there. And she said, you can sit down. I was like, okay. So then the conversation started. She was cooking. And she said, you want something to eat? I said, what you cooking? She said, I'm frying some chicken. I said, can you cook? She said, yeah. I said, okay, well, I'll take some chicken. So me and her sitting there having a conversation. And then she started telling me about stuff she knew. Like, hey, do you know about FEMA? That people can go and sign up for FEMA. Let me tell you how, and she wasn't calling it FEMA, but she was like, yeah, I got a new wash machine and a new dryer. And she's naming off all this stuff. And so it became this whole exchange. And so after that, when she started coming to her appointments, she was like more open and more willing to hear. And if they had a problem, she'd be like, call Miss Hall down. And I would come down like, okay, they would call me down to calm her down. But I enjoyed working with her, and she became an easier client for other folks to work with, all because she just felt like the medical establishment did not care about her at all. And just by me showing up at her house, it just made all the difference. And then when she told me, the difference was made when you ate chicken with me, when you sat down and said, can you cook? Okay, well, I'll eat. If you can cook, then I'll eat something. And we just became, quick friends, talking about, the issues and the stuff that was going on in the community. And she became one of the best advocates for other patients. So determining their readiness for motivation or behavioral change is necessary. Integrating cultural factors into treatment planning. For me, it was going out to her house and being able to talk to her in her own space where she had the power. She could leverage if she wanted to. She could have just shut that door and been like, yeah, don't want to talk to you today. But she didn't. She opened the door and then said, okay, well, you going to come in? Okay. And encouraging patients to be advocates for themselves throughout their treatment. And that's what she became. She became a better advocate for herself. And she was able to advocate for other patients. Like when she found out that other people had the same illness she had, she was able to talk about, hey, this is the doctor you want to see. Go to this doctor because I don't like the other one. And she was real, and she kept it real. And so for that, the people who were in her community respected her for it. And it actually gave me more leverage in the community because she trusted me. Additional do's and don'ts. Developing a relationship with cultural brokers or community gatekeepers. She was a broker, and she was a community gatekeeper. Who are the trusted messengers within the community that can provide you with insight and support. Ensure patients feel appreciated, valued, and in control of their experiences. Encourage feedback and develop mechanisms for patients' input. How do they feel they are being treated? How can you utilize this feedback to improve their care? Are there others that you would think about? The don'ts. Oversimplify cultural understanding. For example, we need more information about the Latino community. Like, you go, yeah, can I talk to you? I need you to give me some information about your community. You're like, who are you? The information should come only from direct engagement. Blame or judge communities for not assessing health services. Well, if they actually went to the doctor, they would be better. It's their fault. Remember, the historical mistrust is directly related to the level of cultural competence within the health system. And then undermine the importance of culture in receiving health care. Everyone should expect to receive services based on their preferences. Discussion. What challenges do you anticipate facing as a patient navigator? So are there any challenges that you think that you face as a patient navigator or as a patient?
Education.
Yeah.
Education.
Okay.
Understanding.
Okay. And so what do you need to do if you're dealing with someone that's having a deficit around education levels, around understanding the wording,
You speak it to their language.
Mm-hmm.
It's easy to understand.
And so we're asking things to be put into a fourth grade reading level, but I would say make it either in a lower level, like bringing things that are pictures for folks, because then they can look at it and say, oh, they can follow it along, and kind of understand what's going on. So education levels, making sure that you're brokering a conversation with people at a level that they understand. Where you ever went to the doctor or somewhere and they're like, people are talking and it's all over your head and you're like, okay, yeah, I need you to talk to me. Or even just looking people in the eye, can change, everything. And so I have thyroid cancer. And so when I started looking for services, one of the things that really pissed me off is walking into a medical center and the doctor immediately starts typing on the computer. Yeah, they don't type when I come in the room no more. Yeah, actually they don't put me in a room with a computer. You don't even get the urge for your hand to move onto a keyboard. because I just think it's so rude. I'm like, I only got 15 minutes with you. And as soon as you walk in, you like, so Miss Hall. And I'm like, yeah, Miss Hall over here. Like, yeah, get your hands off the keyboard and talk to me. And so that's important. So if you were like one of the people who are like, yeah, I can type and see the patient too, don't do that. You know, hear what they got to say, because you may hear something that nobody else heard. They may be telling you something that they've never told anybody else, and that you're looking at their record and you're like, I don't see that anywhere on here. And so now you have an opportunity to engage them in a whole different way, because now they're like, you're actually listening to me, right? And you had something else?
So I was just going to say, is a general thing at the Lupus Foundation, one of the things that we have trouble doing is engaging some minority communities in actually participating in clinical trials. And so I know that and encouraging groups of individuals to, there's a mistrust there. And so I guess I think we try, but it's like we don't always hit the nail on the head. So I don't know what your thoughts are on that.
So when we talk about historical and the historical implementations of for all the programs that we do, for communities that have been have totally been dismissed, particularly I can talk about Black folks. That's what I am. So we always want to talk about Tuskegee, because everywhere you go, the first thing they say is, well, Tuskegee. And I'm like, yeah, I don't really care about Tuskegee. I'm talking about slave medicine. Like, the distrust started with slave medicine, when people were forcefully experimented on without their consent or approval. And then what happened is they either never came back to the plantation, because, my great grandmother would have been 107. And I remember her saying, yeah, you go to the doctor, you ain't never coming home. And I'm like, where'd she get that from? And then I started reading more. And then I talked to her mom. Her mom was still living when I was young. And she would say, I'm like, how come you don't get out of bed? And she was like, yeah, I haven't been able to walk in years, but if I go to the doctor, I'll never come back home. So I'm okay with just being in bed, because at least I can be home. Like, what? And so I'm thinking, what happened? And so has everybody heard of Dr. Marion Sims? He's the father of gynecology. All right. So the father of gynecology actually went and got slaves off of plantations, paid for them, and did experiments with them. He did all types of hysterectomies and other type of procedures on African-American women who were enslaved. And so all of those things have followed us. So remember that genetically, we are who we are. And so when we're talking about our genetic makeup, all of the trauma that our ancestors experienced is part of us. So it's connected. So getting that... How do you get people to separate themselves from their trauma? You don't. So the other thing is talking with them about, hey, if your granddaughter or great-grandchildren, if you can participate in this study, you can help change the lives for future generations of your family that may be impacted by this. Because if I can change the lives for my grandsons, I would. If I could do everything in my power to make sure that other women in my family don't have the same thyroid issue that has robbed me of a lot of things in my life, I would. So those things are important. And those things are important to people, because those things tug at their heart. And so it's not about being in a study for research. It's about being in a study to help change the dynamics that can play out in your family for future generations, and to make sure that your children and that your grandchildren are not plagued by the illness that is desperately just taking everything away from you. Better approach?
And a lot of times it's the person doing the asking that makes all the difference in the world. I'm a Lupus patient. I have all African American doctors. My African American doctor told me about Melissa. So I was, okay, you say it's good then. I'm going to do it. I did it. So now that I've done it, I try to encourage other African American women that, hey, this works. do this. If you can do it, do it. It's the person delivering the message that you have to have a connection to that person in order for that message to come across with my race.
Which goes back to what we talked about, is making that connection with the patient.
You
So,
can make
good.
connections in different ways,
Mhm.
right? Because
Okay.
obviously I'm woman, right? It's like if I sure. I'm one of those things.
Mhm. Person to person. Like, for me, if you, like, I got grandbabies, so if I'm like, if I could change what goes on with my grandbabies, I would want to, I wouldn't want them to suffer like I've been suffering. Yes, ma'am.
Going on your question, the biggest trauma or the biggest hurdle for me is getting my doctors to agree. Okay? And that builds distrust when you run into one that don't go with the rest of them. If they don't all play together in the same field, it's not happening. And that's been my major hurdle. And that's what I tried to ask the doctor before. If you do this, how are my doctors that I trust are involved in this? Because I trust them. I don't trust you so much. I trust them. But I want to do this because I see the benefit in it. So how are you working with them to get this done? Because if you're not working with, I can't work with you. Because I don't know you, and you give me something, I'll be messed up. Not happening. I've been that route
Maybe
with
you
other
should
doctors.
start by asking your doctor, is this a good fit for you? Since you have a team that already work together, you ask them, would they mind you doing this? Instead of starting with the person that's asking.
And that's hard too, because you're trying to build a trust factor with doctors when you're given a 15-minute window. How do you do that?
Unless you go to Dr. Warren.
Well, that's
A lot of patience. But he treats them all the same.
Yes, he does, and I don't want to put any more stress on him.
And I think that's the other thing too, is determining which doctors people feel comfortable with, because then we overload the ones that are really good and they have this. But making sure that we're training up new doctors, that kind of can work with us, and then telling them, like, sometimes you got to educate the doctor too, and say, look, this is what I need you to do, because they need to understand cultural competency and how it plays into their role as a physician. Like, if you're here to save lives, you're gonna start off by shutting your mouth and listening to me.
I mean,
Right.
the doctors I have now, I don't have a problem with them, but when I add a new doctor, it's always an issue. I don't have to talk to that doctor. Oh, you're off the team. Bye-bye, gotta go. And I can't have it.
And they have to be able to communicate, because we're talking about something that's a chronic illness. So they have to be able to communicate, and talking to people and saying, are you willing to communicate with my other physician? And knowing, if they say, well, I'm just going to keep my information to myself. Like, no, you need to work me as a team. Like, this is a team effort. Like, I need you as a team to make sure I'm good. Like, I need the whole armor around me. Yeah. Yes, ma'am. Did you have or were you back there falling out the chair? What was going on? I heard her go, oh! I said, okay, did she want to make a point, or what's going on?
We're going to have you back, because you're an absolute delight. And, I know you've been leading the charge for so long.
My team knows I'm never here. Like, I'm in California doing stuff. So I get a chance to speak all over the country about effectively engaging the African American community, the art of community engagement, because there is an art to engaging the African American community. And a lot of people think that art can be found, but that art cannot be found. It is something that is developed over time. And I've had almost 53 years to develop it.
And I've been striving for over 30 years to break into the community, the minority community, and I have failed miserably, okay? But I have been able to surround myself with other people who are more successful at it, And I also learned about the trust issue for many, and I sat down with many people through my tenure, and I said, well, how do I reach them? I really want to help. And they said, one person at a time. One person at a time. But know this, in Washington, this month, we'll be taking 450 patient advocates from all over the country to go to visit the legislators in Washington, and we are pursuing for dollars for the Office of Minority Health, specifically to encourage or to help the minority communities to engage in studies, because the studies that are going on aren't the drugs that are coming out. They don't have enough candidates in the trials for the minority community. And until we get the participants, we may not find better causes or better treatments. So, you know, there is no I in lupus. It doesn't really know a color. We need all of us to make it work. And we thank you for coming, and you're such a delight. A lot of work needs to be done, and you've enlightened everyone, so we've accomplished a major goal here today. Thank you.
Thank you all for having me.